relation to academics other than this. So post-bypass angioplasty, what is the current status and future directions, role of protection devices on the World Heart Day, 29th. So these are the regular features of coronary angiography post-bypass. You can see RC is occluded, left atrial descending artery is also having disease, and then you see this graft, saphenous vein graft to RCA, OM occluded, OM2 patent. These are the regular features when we do angiography in a post-bypass after a few years. This is how to just tell you that these are the important things, and this is pre and post-angioplasty stenosis here and this. So the plan of presentation will be what are coronary angioplasty techniques, which I am not going to detail. Why saphenous vein graft angioplasty? Why native graft angioplasty post-bypass surgery? When to do and use protection devices, distal or proximal, and then I conclude. So finally, start with the saphenous vein graft intervention. We all know recurrent angina is common in post-bypass patients, mainly due to mid-term graft failure. 50% of the saphenous vein graft are severely diseased or occluded by 10 years of follow-up. 50% of SVG are severely diseased or occluded by 10 years of follow-up. Post-bypass patients represent 20 to 25% of PCI in contemporary practice. At least one saphenous vein graft in 1/3 of these, 7% of all PCI are saphenous vein graft intervention in a busy center. Treatment of disease saphenous vein graft present several specific challenges to the interventional cardiologist. Patients are basically older, sicker than native coronary interventions. Complications including restenosis, distal embolization, much more frequent due to difference in the underlying pathology. If you see the data coming from the long time back, 1999, if you see 94% are SVG, native graft, and 5.7% SVG, and death rate and mortality is much higher, almost 3 times in saphenous vein graft intervention. So we have to learn a little more in saphenous vein graft intervention as compared to the native PCI. The saphenous vein graft, the problem is everywhere. You can see this is how the degenerative graft look like, a very bad atherosclerotic or non-atherosclerotic graft changes, graft failure. Degeneration is the common problem with the saphenous vein graft. And as we know, total arterial bypass is being done in a very few % of cases. Coming on to venous graft atherosclerosis, difference compared to the native CAD. In native coronary artery disease, patient has an often relatively focal disease. There is thick fibrous cap. There is a lipid element generally isolated from the lipid pool, and lesions will be stable for years. Lesions will be stable for years. While here, generally multifocal and diffuse, I'm talking graft, thin or no fibrous cap, foam cells, and lesions are highly unstable and progress rapidly to total occlusion. That is why once you have a saphenous vein graft stenosis, you have to be very careful in treatment and early treatment. And what are the challenges? What are the challenges in saphenous vein graft interventions? First of all, restenosis. Second is distal embolization or no reflow. And here comes the role of protection devices. The first challenge is restenosis. Second is distal embolization when you are doing angioplasty, leading to reflow, role of protection devices, and of course the last challenge is disease progression and graft occlusion. So coming on to the first challenge, so the impact of the stents. Quickly going to the impact of stent. When we started doing angioplasty with the stent, that was 1987 when Ulrich Segbert did the first coronary stenting, and later on it was only basically for the native coronary artery. There was only bare metal stent. Later on, of course, drug-eluting stents came up in 92, 93. So, of course, whenever you start a procedure for saphenous vein graft angioplasty, initially it was basically bare metal stent, and later on they shifted to the drug-eluting stent, and we have a clear-cut data that angiographic restenosis was still in 37% of patients with bare metal stent. And they, of course, some studies were done, DES versus SEVI, and they confirmed, in Belgian trial, they confirmed that if you use a cellulose illuminating stent, then of course the related loss is much lesser as compared to the bare metal stent. So there was no doubt that the drug-eluting stents was doing better, although there was some hesitation earlier to use a drug-eluting stent in saphenous vein graft, and that was taken over very soon. And of course, the conclusion for the DS was that, of course, all saphenous vein graft should be treated with drug-eluting stents rather than bare metal stent. Second component, which is very important for any interventional cardiologist in a busy practice, distal embolization leading to no reflow, and here comes the role of protection devices. What does it do? Distal embolization leads to slow flow, no flow, increased non-QMI, increased MACE, and of course which is confirmed by the rise in CKMB. And you can see the data, despite stenting, CKMB rise, prediction of mortality, stenting has not completely solved SVG problem. that means we have to do something more than just the stent. And this was, you can see this 47% patient had a elevation of CKMB as compared to in native grafts. So periprocedural MI and 30-day mortality was higher when you compare the data with this SVG as compared to the native coronary artery disease. What about GP2B3 receptor antagonist, which is of course intravenous antiplatelet, and it has been shown that this unfortunately long trial, in fact this is a cumulative trial which has shown that GP2B3 receptor antagonists do not add to reduction in MACE or CKMB rise. Then comes the role of protection devices. So there are two types of protection devices. I'd just like to summarize few of them. Distal devices that we distally occlude with the help of occlusion, aspiration of filter wire, and then the proximal devices which are a little more cumbersome to use and not mainly used by many people, but it has advantage over the distal protection devices. The percussion distal protection devices, just to give an idea, consist of 4 components: the guard wire, easy inflator, micro seal adapter, and export catheter. The inflated guard wire and export catheter system, various generational advances in this guard wire with a new EZ emplaster, and this is how it works. The concept is that you have distally occluded it, and then you of course perform the balloon inflation and the stent implantation, and then of course remove the distal protection device, and then of course the flow is consumed, and of course we have to aspirate the whatever is there, the aspiration of this, which protect aspiration of the emboli. This is how it works. Percussion distal protection devices, and you see one by one. This is how you can see the figures. This is first of all the balloon inflation and distal balloon inflation, and then of course performing the angioplasty, and then of course putting the stent, and this is distal protection devices. The SAFER study has confirmed that guard wire versus control, it has shown less MACE, no reflow or less reflow, and of course this is statistically significant if you use a distal protection devices. The second type of distal protection device, first was the balloon inflation, second is filter device, where you put a filter beyond the lesion, and then of course you perform the angioplasty. So the slide is stuck. Yeah. So I would like to show you this animation, which is very important. This is how the filter wire works. This is the protection device which is placed distally. This is the filter. You remove over the wire, of course, on the wire. Then you perform the balloon inflation. The emboli goes and stack up with the filter. Put the stent, deploy the stent. Again, there are few emboli which are again captured by the filter. Removal of the filter wire, and this is the procedure which is complete. So this is how the small animation shows. This is the filter-based distal protection. The concept has been shown, various types, not go into details. The comparison of balloon occlusion versus guard wire versus filter wire, 5 trial which was published way back, it has shown that both are equally important. There's no statistical difference between the balloon inflation versus filter wire. So this limitation of distal devices are there because during time when you're doing angioplasty, you cannot see anything. You have to be very, very particular, you have to be very, very methodical, and you have to be very, very precise. So these are the limitations you have to do. Then comes the proximal occlusion. Occlude the proximal segment. This is how the concept is. And then perform the angioplasty through that, so that when you have inflated, there is no blood flow, and then you perform the procedure. And the few trials have shown the comparison between the distal and protection devices, and the proximal devices have fared better as compared to distal protection devices. Unfortunately, because the proximal device performing this is a little more complicated than distal protection, most of centers are using distal protection devices. Finally, when to use protection devices, the old graft, degenerated graft, long lesion, 2 or more stent thrombus, very important. The high grade lesion, then of course you have to use it. And many cases when you young graft, low degeneration, short lesion, single stent, no visible thrombus, then don't use this. So there are limited indications, but they are of course used, at least they are required in more than 50% of the separate vein graft angioplasty. The last point, which is a very important challenge, is disease progression and late graft occlusion. How to deal with this? 6-year outcome, SVG versus native vessel PCI, practical implication, if feasible, treat the native vessel, especially if the graft is not amenable or it's mildly degenerated. If you have a native vessel, for example, you have an obtuse marginal native, which has got a flow, which is 95% occluded, and saphenous vein graft is is having disease, try to do a native angioplasty. This is the first point we have to. Limiting disease progression. Many patients of bypass cases, they stop the medicine, they just order the ecosprin. I have seen many patients on follow-up, okay, mera bypass ho gaya, so I don't need to take many medicines. It has been shown, a large trial published long time back, New England Journal of Medicine, 1997. Post-bypass trial, 135 patient post-bypass, randomized to high-dose simvastatin, at that time simvastatin was very popular, versus low dose. At fourth year, there was a marked reduction in both the angiographic progression and need for the repeat revascularization. That means statins have to be continued lifelong, irrespective of what is the cholesterol level. This is what the trial shows. All bypass patients should continue on statins. Another role is clopidogrel. Clopidogrel is antiplatelet. Most of the bypass patients, they are only on ecosprin by surgeons or by cardiologists, by referring cardiologists or whatever. But the trial has shown that if you continue 1489 post-bypass patient randomized to clopidogrel versus aspirin, at 36 months, clopidogrel reduced cardiovascular events by around 25 to 30%. So this is the current recommendation is finally use an embolic protection device whenever feasible. Use a drug instead. Of course, there is no doubt, there is no confusion in that. Anticoagulation regime is aspirin plus clopidogrel in all patients, either heparin or biologic or acceptable antithrombin agents. GP2B3 receptor antagonists are not routinely beneficial in post-bypass angioplasty. Finally, just to conclude myself, any case where you have a post-bypass angiography, you have to be very judicious. If you are able to do a native angioplasty of the area which is being supplied by a graft which is occluded, then do the native angioplasty. If not possible, because they take total occlusion, you have to do Saphenous vein graft angioplasty. You have to be very careful. If you have degenerative graft with thrombus, you have to use a protection device to have a good optimal result with PV3 flow, and otherwise you may end up in problems. So Saphenous vein graft angioplasty is a more challenge. And then bypass, and they are at least 7% to 10% of our routine contemporary practice. Thank you very much.
Thank you, Dr. Vivek Gupta, for a nice presentation and the slight change in the order of presentation. And next session will be